It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back and thanks for listening. We have great conferences coming up. ASPN in July. I'll be there teaching ultrasound. I'll be at Pain Week in September teaching ultrasound and regenerative medicine. Hope you guys can make it. Also, you have the Latin American Pain Society in Chile coming up, and ISIP, or New York, New Jersey Pain Conference coming up. And ASIP is this May. I'm not sure if you're going to get this podcast in time, but that's always a great meeting. So, as you know, or don't know, or you should know, I do board prep, and I do get emails from people who've taken the boards, and I don't ask for questions. I don't want to get in trouble with the board. I'm not looking for you to tell me what question was on the board. I'm more interested in what topics are on the board that may or may not have been covered on the Pain Exam board prep, which is located at nrappain.org now, or painexam.com, painexam.com. And I'm trying to always evolve and create the best review possible to reflect what's going on with the boards. Now, of course, there's the FIPP, the ABPM, the ABIP, the ABA's pain exam. So there's lots of different boards, and they're not exactly the same, but there is a lot of overlap, and there are general concepts that are unique to anyone who's testing anything in pain management. And one of those topics is probably the most across the board asked is opiates, right? Opiates are a big part of pain management, for better or for worse. And one of the topics listed here is the differences in gender with respect to the opiate effect. So I found some articles that highlight this and review it. And as always, I'll share the references. Just as a quick update, I am doing ultrasound training in July in New York. Hope you guys can make it. New York is beautiful in the summer. If you cannot, or if you're interested in a more hands-on, intense experience, I am doing private training sessions. I've had, since January, a number of docs come through the office and do one-on-one coaching where they witness live patients, or I coach them at their offices. And it's something that I think if you need to really get up to speed with ultrasound, it's probably a lot more useful than a course, even though the courses are definitely a good way to go. And if you have some comfort with ultrasound already, that's probably all you need, unless you want to take it to the next level. So reach out to me if you're interested in the private training. So back to the topic at hand. In my first article, which will be in the references, there was a study done where they investigated the gender-related effects of opiates in animals. They looked at rats, mice, monkeys, and humans, namely the sensitivity of brain tissue in morphine with the opposite genders. Experiments on rats show that morphine exhibits significantly stronger analgesic effects in males than females. Also, females experience stronger positive effects of morphine, and its action lasts significantly longer with them compared to the males. Now, what I find interesting is they say the stronger analgesic effect is with the males, then they say stronger positive effects of morphine are with the females. So what's the difference here? Unfortunately, they don't specify. It has been shown that the females could bear higher doses of morphine than males, although the morphine concentrations in the brain of the animals of both genders were the same. Remember, these are still animals. Kraft et al. Observed that in contrast to males, lower morphine concentrations exhibited stimulative actions in females. Experimental data indicate the expression of physical dependence on morphine is more severe in male than in female rats during spontaneous withdrawal after chronic morphine administration. That's not surprising. Does it translate to humans? Well, I guess we'll see. However, no gender differences has been observed in the case of naloxone precipitated withdrawal, which suggests that there exists the same degree of physical dependence with members of opposite genders in the course of chronic morphine use. These gender differences in spontaneous opiate withdrawal have not fully been elucidated yet. The possible explanation may be differences in the population density or the affinity of the opiate receptor, or in post-receptor process signal transduction, or it may be related to the effect of sex hormones. Now, I have another reference here that is entitled Race and Gender Disparities in Pain, Treatment, and Opioid Prescribing. This is from 2025, so this is recent as it gets, June of 25. We're now in May of 25, so I guess this article was written in the future, or was published for the next month's. Anyway, you get the idea. So, what does it say? Well, the highlights here are discourse analysis of medical conversations reveal opioid prescription trends. Racial and ethnic minorities are less likely to receive opiates for their pain. White patients are more likely to receive opiates for pain treatment. Physician and patient gender show no significant effect on narcotic prescribing. The role race plays in a pain treatment reveals disparities in healthcare access. Now, I got to just say something right here. As a pain doctor who practices in Brooklyn, New York, with pretty much any color, race, religion you could possibly think of, it's really a melting pot here. The typical, I guess, opiate seeker in the community, that, or the person that you kind of, if you had to like racially profile somebody, which we try not to do, of course, but like just speaking about anecdotally, most of the time, if somebody is drug seeking, it usually is a white male. So, and those are, I could just feel like I'm probably rejecting white males more, young white males, as the people who seem to be more suspicious, not because they're white or not because they're male, just because these are people who just appear to be high risk based on multiple factors. And just as an offshoot, as a pain doctor practicing for like almost 20 years now, I always question myself. First of all, I don't give many opiates. In fact, the minority of patients are on opiates. Most patients do not get opiates in my practice. But whenever I'm sitting on the fence, I always ask myself, why not? And, you want to make sure you're not doing it because of race, because of religion, because of any bias that you may have. And at the end of the day, the answer is, first of all, is it indicated medically speaking? And then secondly, can I trust this patient? Those are, I think, the two answers. And I think the two, one of the big factors that may influence those two answers, if they need it and if you can trust them, is kind of not the way they look, dress, how much money they have. It's really kind of the way they talk. And it's not, I'm not talking about they talk like lower class or upper class. I'm talking about psychopathology. With experience, and I'm sure most of you know what I'm talking about if you're experienced, there's just something that can be off about some patients, especially those who either have an underlying psychological issue that may make them at higher risk for abuse or misuse or diversion, or they could just be a bullshit artist and, maybe your bullshit detector, after talking to 20 to 40 people a day, whatever you do, picks up on that. So anyway, from my training, from my boards, I took the boards in probably 2007, 2008. There were questions like this about racial disparities, and we always said that whites are more likely to receive opiates, which I believe is true. But I also, at least in my neighborhood where I am, the patients who are most likely to abuse are probably the young white males. So those are the people that you're kind of more aware of. Fortunately, I don't really see many people asking for opiates these days because most people are aware of the damage they can do and that they're not really solving the problem for many cases. So anyway, just some personal experience to add to this. So there are healthcare disparities. This is tested on the test quite a bit. Typically, there there's a mention here of 2018 study of pain management patients in African American adults identified physicians' mistrust that they would misuse opiates as a significant obstacle to effective pain management. Black patients were significantly less likely to fill an opiate prescription. Additionally, Anderson in 2009 did a comprehensive review of research articles published between 1990 and 2009 demonstrating the persistence of racial and ethnic disparities in acute chronic cancer and palliative care across the lifespan and in various treatment settings. The findings consistently show minority patients receive lower quality care than compared to whites. I believe that. I'm not surprised. But I think also you could also say, take that one step further and do a study saying, well, do English speakers, native English speakers, get better care than those who don't speak the language or need a translator? Probably yes. Do patients who bring a family member to the office get treated better than those who don't? I'd say probably yes. I mean, I don't have the data for those, but I'm sure that exists somewhere as just a side note. That I don't think will be on the boards, but if it is, I'm just giving you my opinion. I don't know those answers for a fact. Hosted and Sjogren, 2007, suggested physicians unfamiliar with various cultural dependent linguistic practices may be a contributing factor to disparities. Unfamiliarity with politeness, routines, and varying demonstrations of vulnerability can result in misinterpreting patients' genuine cries for help as a drug-seeking behavior. Using corpus-based discourse analysis to study examines the relationship between patients, race, gender, in relation to physicians' prescribing practices across 171 medical interactions. The findings indicate significant predictive relationship between patients and race and physicians and prescribing behavior, revealing that physicians are more likely to prescribe or offer opiates to white patients. Yeah, so I mean, that's usually on the boards. They do test if race is a factor in opiate prescribing, and it unfortunately is. And lastly, there's this article I have that seems to be somewhat comprehensive, where they really did a large study looking at the differences between men and women in humans and opiates. I'm going to just review the discussion briefly and let you check out the link yourself, which are on the show notes. They mentioned that men and women demonstrate similar degrees of aberrant drug-related behavior, although gender differences were found in the risk factors for misuse of prescription opiates and in the way men and women are classified as having aberrant drug-related behavior. From the results of a structured interview, women tended to endorse items that are based more on emotional issues and affective distress compared with men. Conversely, men had higher scores on opiate misuse behaviors, such as associating with others who abuse drugs and alcohol and engaging in criminal behavior. The discriminant analysis shows that women with aberrant drug-related behavior were much more likely to admit to a history of sexual or physical abuse or a history of psychiatric or psychological problems than were men. These results are in agreement with the past research that highlighted the importance of sexual and physical abuse history in prescribing opiates. The same studies also showed that women with a significant history of anxiety and depression tend to do less well in properly managing opiates prescribed for pain, possibly because of tendencies to self-medicate a mood disorder with using opiates. Men in the present study, on the other hand, reported fewer mood problems and appeared to be more prone toward behavioral problems leading to opiate misuse. It is especially noteworthy that specific problematic aberrant opioid-related behaviors assessed at follow-up were more frequent in women when assessing a self-report interview, but were more frequent in men when assessed by treating physicians. Given that many of the structured review, or the PDUQ, items involve psychological distress. The finding may be explained in part by sex differences that are observed consistently across lifespan. Women are more likely than men to report distress. In contrast, men are more likely than women to display problematic social and interpersonal behaviors, and these may alert physicians to potential medication-related problems. And it was also noteworthy that more than one-third of the subjects were positive on the ADBI, which is the Aberrant Drug Behavior Index, and they had abnormal urine screens. A smaller number of pain patients may have an addiction disorder and may require more intense services from a substance abuse center, these individuals probably would endorse items that are much more problematic. Do you believe that you are addicted to your pain meds? Questions like that. Or have any family members ever expressed concern that you might be addicted to your pain medication? And to your knowledge, have you ever been diagnosed as having an alcohol or drug problem? Gender differences were not found on these items, suggesting that the frequency of frank addiction disorder may be unaffected by gender. Indeed, other factors such as personal or family history of substance abuse, age, and psychiatric history may be substantially more powerful determinants than gender of the development of opioid addiction. Once again, this is great for your knowledge as a doctor and your practice. It's not clarifying that much for the boards, unfortunately, right? Surprisingly, some demographic factors were not useful in differentiating men and women, in particular age, duration of opiate therapy, pain intensity, social desirability, and overall SOAP scores, which were not predictive of gender differences. As found in this study and noted elsewhere, a greater percentage of women prescribed opiates for chronic pain tend to be unmarried, divorced, or separated compared to men. It is unknown if this is related to the negative effects of chronic pain or if the women prone to chronic pain also prefer not to be married. Good point. We also note that the incidence of headaches was found to be greater in women than in men, keeping with other studies. Overall, fewer demographic effects were found among men and women, and demographic factors were not found to play a role in predicting opiate misuse separately for men or women. They did mention 3 clusters of variables appear to be most strongly predictive for issues with opiates, such as history of substance abuse, history of legal problems, history of psych disorders, which all make sense. Past research suggests that women tend to be more open to admit or to be more to more problematic behavior, seek psychological treatment more often than men. And it's possible that the study that I'm referring to reflects gender differences in willingness to admit to behavior captured through the self-reported SOAP or PDQ scores, even though no gender differences were evident in the number of abnormal urine screens and the aberrant drug behavioral index. It is possible that women misuse their opiates medication in different ways compared to men. For instance, women may tend to overuse their prescription opiates because they are distressed, and the medication is used to help stabilize their mood and to help them relax. Men may be more affected by environmental factors of associating with others who are prone to illicit substances. So skipping to the end because I need to get busy and see patients. Despite these limitations, the result of the study suggests that the correlates of problematic opioid use may differ in function of sex, with women more likely to endorse psychological distress leading to aberrant drug-related behaviors, and men less likely to report emotional issues, but more likely to have a history of substance abuse and legal problems that predispose them to misuse. A recent review concluded that identifying chronic pain patients at the greatest risk for opioid abuse and misuse remains a difficult challenge and requires more research. They hope that the present findings may help guide additional work evaluating potential sex-specific predictors of misuse. Anyway, I hope you found it useful. I think it's definitely useful for your practice and your career as a doctor. For the boards, somewhat useful. I'm worried that they're creating board questions based on one study, and then that study may differ from what other studies show with respect to gender differences about pain. So anyway, I hope you guys find this useful and stay in touch. Please feel free to contact me if you're interested in any further training, whether it's ultrasound or if you want to hear of a different topic discussed or be interviewed on my podcast. Please share it with your colleagues, anyone interested in pain, whether they're pain docs or other types of physicians or even patients. I get a lot of patients who listen to this podcast, and sometimes they reach out to me or come to my office as patients. Anyway, thanks for listening. I appreciate you, and have a great day.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.